Welcome to the 516th episode of the Jami Dulaney Plant-Based Wellness Podcast. My name is Jami Dulaney, and I'm your host. I'm a plant-based cardiologist living in Southwest Florida. Welcome. Happy Easter week. Happy Passover. April is marching through. We had tax day, and in a week, I'm going to have the Skunk Ape Revenge 50-mile race. It's heating up down here so far. We're having some nice cool mornings, but the weather forecast for next week is hot, so look out. It'll be a lot of practice in hydrating, some heat training. I think it's going to be somewhat covered, so hopefully it'll be a bit shady, but we'll see. Lots of things to learn and experience. I'm looking forward to it. Training's going good. I'm in a bit of a taper, starting to anyway, so I'm real happy about that. So this episode is about risk versus benefits, risk versus rewards. We have to take risk every day. We take a risk when we get in our vehicle. We take a risk if we get on a bicycle. There are risks and benefits. We take a risk if we take a medication, if we have a procedure, if we don't do a good diet or exercise, we're at risk. So there's all kinds of risks versus benefits, and we get to decide as individuals what we accept as a risk and benefit. However, when it comes to medicine, it's not always presented directly to the patient, and sometimes there's an interpretation by the provider, physician. Sometimes we don't talk about all the risks. Maybe as a physician, we're biased about some of the risks. Sometimes people don't want to hear about the risk. Sometimes there's a lot more benefits. It can be a tricky path to circumvent. In addition, a lot of our data comes from studies, and if we apply the statistics of a study to one person, obviously it's not all that accurate. And when we have lots of percentages here and there, it's very difficult. And so we have to ultimately make a decision on what we perceive as risk, reward, benefits. Ultimately, we're looking for the greatest benefit with the least amount of risk when we're talking procedure or medications. But there's really none that exist that don't have any risk to them. As a matter of fact, as we get older, our risk of dying increases each year. So we don't live without risk at all. We're just trying to figure out how to navigate it to the best of our ability to live as long as we can, as healthy as we can. Sometimes we hear the number 2% or 3%. It seems pretty low. After all, if you say it's a 2% risk but a 98% chance of benefit, then odds sound pretty good, unless that 2% risk is something as bad as death and perhaps a stroke. There was a professor at Stanford during the middle stages of COVID that I think put it very much in a good light or a good perspective when talking about the mortality benefit, or I'm sorry, not the mortality benefit, but the risk of dying from a COVID infection. And obviously we all have a risk to some degree of dying. And again, a child has much less risk, much less than 1%, and 90-year-old has much greater percent of chance of risk, someplace 5 to 8% perhaps every day of their life. And the reality of it is maybe jumping out of an airplane has a 6 or 7% risk of something bad happen. If you're young and your risk of dying is less than 1%, but you undertake a activity that has a risk of 5 or 6%, obviously that would be a risky type behavior. On the other hand, if you're 90 years old and you have a 7 or 8% chance of risk of dying every day, then a risk of jumping out of an airplane at 5% is not that bad. And so he reasoned that if you were going to jump out of an airplane, you probably should do it when you're 90 because the risk is much less than it was even in the beginning when you got up in the morning. And basically that was the way it was for COVID. Older people had more risk of having about bad outcome than younger people. But in it quickly got turned around that everybody had the same risk. And it became very frightful. If you said a child had a 2% risk of dying from COVID, that would be very scary. But in fact, it turned out not to be true. But that's not the same for everything that we come up across. You know, the big thing out there now is measles, and measles making a comeback, blaming people that aren't vaccinated. But the risk of a vaccination certainly exists. Back in the late 60s, when I was vaccinated, I actually got the measles the day after I got vaccinated. But nobody was afraid of the measles. It was an infection that most people got. They were home from school for a few days. They had flu-like symptoms and fever, but nobody really had a bad outcome. Didn't mean it didn't happen, but it was very low risk. Unfortunately, in the practice of medicine, we start to assume what that risk means for our patients. And I have obtained consent for cardiac catheterizations many times, and I have quoted the risk of stroke, heart attack, or death being 1% to 2%, and was very confident that the patient wasn't going to have that complication. 90% chance you're not. If you're healthy going in, you'll be healthy coming out. And that risk was mitigated. But it was a possibility. And certainly there are episodes where people have an adverse outcome with cardiac catheterization. But it's somewhat rare. But when it happens to that individual, it's real. I guess this is leading up to an event that I have been a part of this week, in that patient of mine had a stroke. And the team at the hospital was very good. The interventional radiologist did an excellent job at getting the clot out of the middle cerebral artery. He also got a very potent blood thinner called TPA, and the risk of bleeding after that procedure was very high. The risk of dying from that the risk of dying without that procedure was also very high. So we have an older person that had a very high risk of something bad happening, taking a risk that had risk to it, having a procedure done that had risk. But again, at that moment, the benefits clearly outweighed the risk of the procedure, and he got through it. He did have some bleeding afterwards, which is common when you get a blood thinner and have such a procedure. Thank goodness, he's doing fine. But everyone seemed to, or I shouldn't say everyone, but the physician, the hospitalist, neurologist, intensivist, seemed to take for granted that that was just part of the risk-reward situation that occurs. And he wasn't alone. It's for everyone that was in the intensive care unit. The risk of dying if you're in the intensive care unit is elevated. And it's a risk that everybody is comfortable in taking, and everybody becomes very comfortable at assuming that that's just part of the circumstance. And people become somewhat calloused over that. And sometimes to the point where people don't ask, is this the best route of treatment? What is the data? And people don't have time to think about it. Unfortunately, in intensive care units, sometimes things move very fast, and you have to act on protocols in order to get things moving, certainly a code. There's a protocol on how you proceed with resuscitating someone, and obviously the risk of dying is very high if you have a cardiac arrest, so you follow this protocol, and if you win, you win, and if you lose, you tried your best. And I think that's the problem I have with today's medicine, is we tried our best, and we accept that too easily. We don't take time to think enough. Is this our best effort always? Is there something else we could do? And even more, what can we learn from this patient so that it won't happen to someone else, or that we can improve the care of someone else if it does happen? And I guess it's because I don't have that many patients in the hospital and I have time. and I have time to think and time to sit back and time to observe. But it was very bothersome that people were so comfortable with the potential of a bad outcome, especially since my patient was involved. Thank goodness I had the opportunity to discuss his case with a very good friend of mine who's the best neurosurgeon that I've ever met, and a cardiologist that I just met for the first time that happened to be this person's cardiologist in another state when he summers there. And we had a discussion on how much that we don't know when it comes to strokes and the care of strokes and the cause of strokes, and particularly when it involves an arrhythmia called atrial fibrillation. And you may have heard of it on this podcast. You may have heard of it on TV with the advertising of blood thinners that you take and decreases the risk of a non-valvular AFib stroke. And it always talks about the benefits of the blood thinner, not necessarily the risk, but it comes down to atrial fibrillation is an irregularity in the top chamber of the heart, where the top chamber quivers at about 250, 300 beats a minute, and the bottom chamber tries to keep up. And typically the bottom chamber can't keep up, so it may beat as high as 180, or if the person's older, it maybe not beat much more than 80 or 90. But regardless, that top chamber, because it's quivering, the blood doesn't circulate well. And there is a little left atrial appendage, kind of like a jalapeno pepper, that is kind of the ear of the left atrium. And when that blood is not circulating well, blood can pool down into that appendage and clots can form. And the thinking over my career has been that the longer you're in this arrhythmia, the higher the risk of stroke, and blood thinners should be started. And the treatment has evolved over the years. We used to have only one blood thinner called warfarin, which was affected by what you ate and vitamin K. So if people ate a lot of green leafy vegetables, it would actually thicken and counteract the coumanin level, and their blood wouldn't be thin enough. If they didn't eat any green leafy vegetables, then their blood might become too thick. If antibiotics, because it would kill the bacteria that was part of the process of making vitamin K, would cause their blood to get very thin. So you had to monitor it every couple of weeks to once a month, depending if someone was stable, and certainly if somebody had something done. The good part about warfarin was that you could reverse it by giving blood products called fresh frozen plasma and reverse it pretty quickly. Type and cross, infuse the plasma, and the blood would be thickened up. And you could also give vitamin K, a little slower, but nevertheless the blood would thicken up if you had an emergency. So if you had a cut, or you had a fall, or you were in a car accident, or you had to have a surgery, you could reverse the coumanin level, which is called an international ratio, INR. The advent of newer medications that aren't affected by what you eat or antibiotics came along, and they were once a day or twice a day medications, and people were automatically fully anticoagulated. So one pill got you where you're going, and you didn't have to load it up like coumanin over 3 or 4 days, and it became much easier to manage, and the levels were much steadier, and became pretty much the standard of care in most patients that didn't have mechanical valves. But the problem with these new medications, the brand names Xarelto, Eliquis, is that you can't reverse them very quickly. There are some new medications for emergency, but for the most part, you're looking at about 48 hours to get some of these things reversed. And so if you have a cut or a bleed, you kind of have to ride it out and potentially get blood products and wait for the medicine to actually wear off. So the treatment then advanced, and does everybody need blood thinner for atrial fibrillation? And how long can you be in atrial fibrillation? Can you be in an atrial fibrillation, and when does the risk start to occur? And again, that's evolved over the years because we're looking at a giant population. Early on, it was thought about 7% of people with atrial fibrillation would have a risk of a stroke, 7% increase over the general population. Doesn't sound like much, but again, if you're 60 years old, your risk of a stroke is pretty low, so 7% is pretty high. So if you had atrial fibrillation, 7% increased risk of having a stroke. Well, then we start looking at risk factors for atrial fibrillation and risk factors for a stroke, and there was a score that came out, and you can even Google it, CHADS type score, and it took into account if people, their age, because the older you are, the more risk you have of having a stroke, even if you're not in atrial fibrillation. So it became less than 65, 65 to 74, and greater than 75. And you were assigned a score. Less than 65, the score was 0. Greater than 75, the score was 2. Women were thought to have a higher risk of stroke than men, so they were given a score of 1 for females. If you had a history of heart failure, you got a score of 1. Hypertension, you got a score of 1. History of a stroke, you got 2 points. Vascular disease of any kind, you got 1 point. Diabetes, you got a point, because diabetics have an increased risk of stroke. If your CHAD score was greater than 2, and certainly you were to very strongly consider blood thinner. If it was greater than 3, then it was an absolute recommendation, or I strongly recommended that people be on blood thinner. On the other hand, if it was less than 1, no. However, even if you had a score of 0, you still had about a 3% risk of a stroke per year untreated. And again, these would be in otherwise healthy people that the risk of stroke is not that high. So we're taking the risk versus benefit in the younger person and saying the risk is low, you don't have anything else. If you're not in this rhythm very often or it doesn't last very long, you're probably going to be okay. But it's certainly not an absolute. We used to think 24 hours was the magic number. If you were in atrial fibrillation 24 hours, it became an increased risk. And then we backed it up to maybe it was 12, maybe it was a couple hours, maybe any. It increased your risk because we thought, because if you look with an echocardiogram, that their left atrium, and especially that left atrial appendage, that jalapeno pepper attached to their heart, did not start to act right for several weeks after people regained a normal rhythm. So for an example, if you went into the atrial fibrillation rhythm and your top chamber was quivering, and then you were given a medication or cardioverted and you're back into a regular rhythm, it would take 4 to 6 weeks before your heart really came back to true good function. And it was thought because that left atrial appendage, maybe there was clots formed in there, and when you start to have a normal contraction, the better your heart started to contract, you start to flip these clots out. So that's when the risk, we thought, occurred. On the other hand, with the invention of a transesophageal echo, which I was a part of way back in the 90s, we could see the left atrium very clearly because the scope went in the esophagus that sat right behind the heart, and we could see what we called smoke in the left atrium. And it was literally a swirling of the blood. So all you people that have Vitamixes out there, when you see the smoothie swirling around in the bowl of the Vitamix, that's what the left atrium would look like in people with atrial fibrillation for longer periods of time, or if their heart function wasn't good. And if they were, then you didn't see that. You assumed that there wasn't those clots forming around and things were better. But again, it's not an absolute. More evidence on your side that things are going to be okay, but less, couldn't be completely without risk. So if we saw it, it was a bad thing. If we didn't see it, probably a good thing, but couldn't be really sure. And now we're starting to see that it doesn't matter when you had the atrial fibrillation, and that clots could occur anytime, perhaps. And again, sometimes they are a result from that left atrial appendage, and sometimes they come from that left atrium. And there's no way to really be sure. So what do? It got more complicated when the person had a fall and had on blood thinner. So if you're on blood thinner and you have a fall, you hit your head on the car, you pull the hatchback of a car down on your head, you can have bleeding. You can have bleeding on top of the brain, under the skull, which is called a subdural, and the dural, the kind of the coating of the brain, like the shower cap of the brain, so to speak. You can have a bleeding there, which usually is less severe, or you can have bleeding within the brain called a subarachnoid bleed, which is much harder to deal with. Younger people that have bleeding in their head, it's much more serious because they don't have as much room in their skull for their brain to expand. Older people have some shrinkage of the brain, and so there's a little more space for it to expand, because if you have bleeding, you also have swelling if you have a stroke. And so the risk, if it's too much bleeding, it causes the brain to kind of go down into the, squeezes basically the bottom of the brainstem and can cause death. So bleeding is a bad thing. So if someone has a major bleed or they have a GI bleed while they're on this blood thinner, we have to stop it. And then we sit in that space called the risk of potential of a clot or a stroke. There are some people that the risk is so high, we never put them back on blood thinner. They fall so much, they're old and they're feeble and they can't get around, and they're not on blood thinner for years and they don't have a problem. And then there are people that go off, or maybe they never started and they presented with a stroke the first time they ever had atrial fibrillation. And I've seen that with a massive stroke. The first time the person ever was seen with atrial fibrillation, they had a massive stroke. Didn't see it coming, didn't feel the atrial fibrillation. And that's atrial fibrillation and the blood clots are a huge cause of strokes. So if you can't feel the arrhythmia, then you don't really know what's going on. I love wearables. Meaning Garmin's and Apple Watches and cardio devices where you can do your own EKG, and you can do your own EKG on an Apple Watch. I love those because people can actually look at the data and see whether their heart rate is kind of goofy. So if you see your heart rate go up for no apparent reason in the middle of the night, maybe something's not right, and you should check with your doctor. Or if you feel palpitations and you can do an EKG and send it to your doctor, that's great. You can pick up these things rather quickly. You have to notice it, and you have to use these devices, but they're excellent if you own one to kind of look at your own heart rate and see, as you know, my heart rate's usually 60, but all of a sudden now it's sitting at 90 when I'm watching TV. Something's not quite right. I should talk to my doctor. That can be life-saving to use these devices. But it's not foolproof because sometimes the devices aren't quite right. You can have a blip in your heart rate for no apparent reason that just didn't make good contact, or maybe you didn't notice it. So that puts people at risk as well. So the question comes is, once somebody has some bleeding complications from these blood thinners, what do you do? When do you start them back? When is it safe? After surgery, when is it safe? We often see bleeding complications, people that have hip replacements, knee replacements, and they have, they're put on blood thinner, or they're taken off their blood thinner to have the surgery. Then we want to start it, but if you start it too soon, then sometimes they bleed into the incision and has to be stopped again. It can be very, very difficult to manage, and it makes the procedure much, much more risky. So we don't really want to start these medications if we don't have to, but the risk is there. And I guess my point in all this is people need to understand what the risk is, and they need to be educated enough so they can make that decision, knowing full well that I can't predict that risk any more than they can actually predict that risk. And I think that's probably one of the most disheartening things, because people can have, despite no atrial fibrillation, they can still have blood clots. Taking the people off medications for procedures may result in increased episodes of blood clots. We just don't have a real good handle on how to manage these in all cases. There's a risk. And as people get older, the risk gets greater. if you have a symptom of a stroke, sudden onset of one-sided weakness, you never get a stroke on both sides at the same time. So if you feel weak in your left and your right arm, it's not a stroke. But if you have left arm weakness, left arm, left leg weakness, right arm, right leg weakness, if you have a droop in your face, if you have a blind spot suddenly, if you see a curtain coming down over your eyes, like a black curtain is coming down over your eyes, if you have the inability to talk, or your speech is garbled, or you can't find the words all of a sudden, these are signs of a stroke. The quicker you can get medical attention, the better. Don't sit on it. It's better to be evaluated and be told that you're okay versus there's something going on. Obviously, eating a plant-based diet decreases your risk of vascular disease, stabilizes plaque, and makes you less likely to clot. But if you have these arrhythmias, doesn't matter if you're plant-based or not, these arrhythmias can occur. They can occur in athletes, they can occur in people that have drank a lot, they can occur people that have valvular heart disease or high blood pressure or COPD or have had pneumonia or have sleep apnea. So there's a whole host of reasons why people can have atrial fibrillation despite being plant-based, perhaps. And being plant-based does not decrease your risk if you have atrial fibrillation of one of these embolic events or clotting events. People call me all the time. It's like, I want to get off my blood thinners. I want to go plant-based. Can I come and see you? And it's like, you can, but I can't fix your risk of a stroke with atrial fibrillation with plant-based nutrition. I wish I could. That'd be great, but I can't. I can fix your risk factors so that if you've had atrial fibrillation once and you get your blood pressure under control, you get your sleep apnea under control, you get your weight and diabetes under control, you may have less episodes. You may never have another episode, or certainly they may decrease, but it's not 100%. And despite people's best efforts, sometimes they have recurrence of their atrial fibrillation. You can have an ablation, and the ablation can fail, and you can have atrial fibrillation. And then you can have an ablation and have no atrial fibrillation and still have a stroke. So there aren't any 100%ers. I think that's the main point. But it's very important that you communicate with your physician. And I think it's very important that physicians know their patients well enough to know what their thoughts are and what they do, what their activities are, so that they can speak openly and honestly with their patients. And I think as physicians, we need to care for people individually and have their best interest at heart and do everything we can, even if there is a bad outcome, to sort things out and to keep trying to improve our care for that patient and for other patients. There's also a device called a Watchman that you can kind of close off that left atrial appendage, or when people have an open heart surgery, they can have that appendage closed. But again, there's still a bit of a risk, maybe up to 10% risk of having a clot in the left atrium. So nothing's for certain in this life. And when somebody says there aren't any risks, that's when you know when somebody's not being very honest with you. And it's my job as a physician to inform people the best that I can and to take care of them the best that I can with whatever happens. And I am thankful for my colleagues that feel the same way, that are bothered by bad outcomes, so that we can learn and try to figure out how best to do things in the future. I often ask, what would I do if it were me? What would I do if it were my family? And I've actually had to deal with it with a family member. And I've had to deal with bad outcomes with a family member. So it's not an easy decision to make. It also makes me realize how fragile life is and how we shouldn't take any moment for granted. And if there's anything we can do to decrease our risk of things like atrial fibrillation, stroke, heart attack, cancer, then it'd be a great idea to try. And I think plant-based nutrition is a way to get at those risk factors and certainly being fit, and exercise. Thanks for listening to my diatribe. My patient is doing well. If you would like to learn more about atrial fibrillation, cardiovascular disease, reversing risk factors, plant-based nutrition, hop on over to our website, drdulaney.com, DOCTORDULANEY, and check it out. We'd love to help you. I don't have a miracle cure. Nobody else has a miracle cure either, but I do have compassion, and I work with people the best that I possibly can to prevent them from having more risks than benefits. Enjoy your holiday weekend. Thanks for listening.